Hey everybody, welcome back. In this video, we're going to take a look at some MRI reports and go over a few examples. And hopefully by the end of the video, you guys will understand some of the terminology and what it means when you read your own MRI reports. Okay guys, so what I've got now on my computer is some MRI reports that I'll put up on the screen here. We're going to go through each one of these and review pretty much what is on the MRI report, and then we will kind of go through what all that means. So on this first MRI report, what you'll notice, every MRI report is a little bit different in terms of their format, but in general, they're pretty close to the same. And so if you look up here, you'll see what the actual study is. So on this one, we see MRI of the shoulder. It'll say the side, right or left, and you might see with or without contrast. And contrast refers to usually in the context of rotator cuff problems and things like that, they're referring to contrast, which is actually injected into the joint, and that's called an arthrogram. And that helps to look at certain things in the shoulder, maybe help clearly define different types of injuries and things like that. For rotator cuff problems, you typically do not need contrast, but if you're looking for labral tears, like if in a shoulder dislocation or something like that, a slap tear perhaps, adding the contrast inside of the shoulder can be helpful to see that a little bit better. So in this MRI, we have one without contrast. And then what you'll see here is an indication, and there's this code here. And really that just provides rationale for the actual study. So in this particular patient, we see that there was concern for rotator cuff tear, an incomplete tear in the shoulder. You also see shoulder pain and things like that. And so that helps rationalize the indication for the actual MRI. You'll see technique. Multiplanar means you're getting images in different planes, like a coronal, sagittal, axial plane. And I've got other videos on that you can review to understand the difference between those two. And then you'll see, you may see comparison, and this refers to the radiologist. This refers to the radiologist having multiple images of the body part in question, and so the radiologist can make comparisons. Say if this patient had an MRI done a year ago or something like that, and then the radiologist can actually compare that. So in this particular patient, there was no comparison. And then they get into the details of the report under findings, and then further down you'll see sort of a summary called the impression. So if we go back to the findings here, different radiologists sort of organize their thought and their report in different ways. So you might see some difference with that. But here we'll see bones and cartilage. And then there is moderate, and so the radiologist, there may be ways radiologists grade certain findings and ways that orthopedic surgeons might grade certain findings, and the way that's interpreted might be a little bit different. And so you should really discuss that with the ortho surgeon who is reviewing the report with you. And so there's moderate glenoid. The glenoid is the socket of the shoulder. And mild humeral head, which is the ball of the socket, chondromalacia. And this term chondromalacia refers to sort of a spectrum of change of the cartilage of a joint. So it could mean anything from just some subtle softening all the way to some a little bit of wear and tear, to perhaps like fissuring and cracks of the cartilage, all the way to the beginnings of osteoarthritis of the joint, which is really where the cartilage of the joint is totally worn out and you're starting to get bone-on-bone rubbing of the joint. And then next here they say no subchondral cystic change. So the subchondral part of the joint refers to the bone that is just underneath the cartilage layer. Cystic change is something that you would see typically if there's osteoarthritis. And so they specifically want to point that out. Type 2 acromion. So the acromion is part of the shoulder blade, actually. So here's our shoulder here, and here's the arm bone on the shoulder blade like this. And so the acromion is part of the shoulder blade where it comes out over the lateral part of the shoulder and overhangs the top of the arm bone like this, just like that. And so that's the acromion. And so when they refer to a type 2 acromion, they're referring to sort of the shape of the acromion. And so many years ago, when surgeons, doctors, researchers were trying to understand the causes of shoulder pain, they would classify the shape of the acromion. And so some are very flat, some are curved, and some are hooked. And it was thought that patients who had more of a hook type acromion might lead to more impingement and rubbing of the rotator cuff. This next one, moderate AC joint DJD. So the AC stands for the acromioclavicular joint. So again, if we go to our, let me reach back here on my other shoulder model. So if we bring my other shoulder model here, the acromioclavicular joint refers to where the collarbone meets the acromion. And so there's a small joint right there called the AC joint. And so when the radiologist says moderate AC joint DJD, what they're saying is degenerative joint disease, and you could just think of that as osteoarthritis. So this patient's having some cartilage wear and tear of that joint, and they're developing some arthritis change. No suspicious Marrow signal. So what they're referring to is maybe cancerous change, perhaps. Signal is on an MRI. Refers to predominantly fluid signal changes within the bone and the way the MRI presents certain types of pathology. And so essentially what they mean here is that they don't see anything that's underlyingly suspicious and more concerning than what they've already pointed out. Then moving along here, labrum. So the labrum, if we think of the shoulder joint as a socket, so if I can open this up for you like that, you could see the shoulder socket right there. And then around the shoulder socket is a structure called the labrum. And here they're saying there's labral degeneration without convincing tear. And so essentially what they mean by the labral degeneration is, I would think of it in this particular patient just like the age-related wear and tear of that labral structure. In younger patients, athletes, you can get labral tearing as a result of an injury that is clinically significant. But as patients get into their 40s, 50s, and above, it's very common to see labral degeneration, and it's not typically part of the reason why the patient's having pain. So moving down to this next topic, or the next heading here, we have the rotator cuff. And they say here supraspinatus and infraspinatus tendinopathy. So the supraspinatus and infraspinatus represent 2 out of the 4 rotator cuff tendons. And they mention this term called tendinopathy. And so the easiest way, I think, to think about tendinopathy is the progressive wear and tear change of a tendon. Tendons on a microscopic level are made up of these fibers called collagen. And as wear and tear happens, you start to get fragmentation of that collagen. You can start to get disorganization, degenerative changes, perhaps some inflammation, and even some failed tendon healing. And it may or may not start leading to symptoms or loss of function. And so there's different degrees of that. It can be really mild or it can be really severe. And the next thing they point out here is intermediate grade footplate tear along the supraspinatus. And so when they say a footplate tear, really what they're referring to is where the rotator cuff tendon attaches to the arm bone. So we call that the footprint. They refer to it as the footplate here, pretty much the same thing, and of the supraspinatus tendon. And then they'll mention, sometimes they'll put a location of where they see it. And so in this one, this is image 16 out of series 6. And so that just refers to the actual image. So I can specifically go back and look myself at what they're seeing. They mentioned a questionable low-grade minimal footplate tearing about the infraspinatus. So the infraspinatus is another one of the rotator cuff tendons. And so it sounds like in this particular case, it's a little unclear, but they might see a small tear at the footprint of a second rotator cuff tendon. And again, they mention the location of this. And then the subscapularis demonstrates tendinopathy. So the subscapularis is another rotator cuff tendon. So that's 3 out of 4 tendons that they've mentioned in this particular report. And they're seeing tendinopathy, and a small footplate tear is suspected. And so, so they see some wear and tear of the subscapularis, and they might see a small tear where that subscapularis attaches to bone. And then finally, they mention the teres minor is normal. That is the teres minor is the fourth out of the 4 rotator cuff tendons. There's no muscle atrophy, meaning the muscle looks healthy. And they move on to talk about the biceps tendon. So if you remember, the biceps actually, maybe we got a better picture here. Yeah, so the biceps runs from the arm bone up into the shoulder socket. And so biceps runs and dives deep into our shoulder socket. And so they make a note of that and what that looks like. And so they say that looks normal. And then the rest of the soft tissues they make a comment on some of the other tissues around the shoulder. And so they say moderate subacromial and subdeltoid bursitis. So the subacromial space is this space underneath the acromion, which effectively is the rotator cuff, where it comes in underneath the acromion bone, just like that. So there's the acromion, and the rotator cuff comes underneath. And underneath that space is called the subacromial space. And the subdeltoid space is the entire space that's underneath your big deltoid muscle. And so they say there's bursitis there. And so a bursa is a tissue layer that essentially allows low friction motion between 2 different layers, and they see inflammation in that layer. That's what they're saying there. And then finally, we come to the impression, and they point out 1, 2, 3 different points that they really want us to focus on, and they summarize really what we've said in the above report. And so that's going over that one as our first example. Okay, everyone, we are on case 2 now, essentially the second example. So we're going to start off at the beginning of this MRI scan report. We see once again this is an MRI of the shoulder. It's a right shoulder without contrast. The indication for the clinical indication for this MRI is a suspected rotator cuff tear or rupture of the right shoulder. The technique is an MRI of the right shoulder. It says, again, multiplanar sequencing or imaging, which just means that you're getting different perspectives on the image. And in this patient, like before, there's no comparison study. So she hasn't had a previous MRI or that the radiologist can compare this to. And so as we scroll down, we'll look through the findings here. And so here we are on the findings. So they just start straight off. There's extensive rotator cuff tearing. So they're already letting you know that there's a lot going on here. There is a complete full thickness tear of the supraspinatus tendon. So remember, the supraspinatus tendon is is one of the 4 rotator cuff tendons like we talked about before, so we'll bring our models up in case we need them. So they're saying that there's a complete full thickness tear of at least one of these rotator cuff tendons. So the tendon is totally torn from the bone on this particular tendon. And then they make note, and there's full thickness tearing of the infraspinatus tendon. So that's 2 out of the 4 rotator cuff tendons where the radiologist sees complete tearing. They do say that there's sparing along the posterior aspect. So what I think that they're describing is that that the supraspinatus, which is about here, is totally torn. But they're also saying part of the infraspinatus, which is a little further back in the shoulder, is torn, but there's still part of it in the back that's still attached. So a part of that infraspinatus, it sounds like, is totally torn from the bone. And then they say with up to 3 centimeters of tendon retraction. So what they're saying is, we'll come to more of our tear model here. What they're saying is that this tendon, where it attaches to bone right here, they're saying that tendon is torn and retracted 3 centimeters away from the bone. So that's a pretty big tear. And then they also make note that there's a 3 centimeter AP fluid-filled rotator cuff defect. And so they're making note that there's a tear going from outside the shoulder towards the inside, so tear in this direction, coming out like, coming off like this. But they're also saying that if we look from the side, from the front to the back, there's a 3 centimeter tear here as well. So again, a pretty big tear in this patient. They're making note that there's moderate supraspinatus and infraspinatus tendinosis. And so there's the term tendinosis, which essentially means the same thing as tendinopathy, that progressive wear and tear of the tendon tissue. And then they say that there's no muscle belly atrophy. So even though the tendon is torn from the bone, the muscle itself looks healthy. So moving along, they say there's also moderate subscapularis tendinosis. So they've now mentioned 3 out of the 4 rotator cuff tendons that they see pathology in: the supraspinatus, infraspinatus, and now the subscapularis. And they say that there's a low-grade interstitial tear at the musculotendinous junction. So an interstitial tear is not, so if you think of a tendon tear from the bone, where the tear is actually coming from the bone here, an interstitial tear is more of a tear within the substance of the tendon itself. And it's specifically at the musculotendinous junction. And the musculotendinous junction is about here. So looking here at this model, here's the red. This is the muscle part, and the red muscle will slowly start to blend into the white tendon. And so that's the musculotendinous junction where that transition occurs. The next paragraph here, the long head of the biceps tendon is intact. Again, remember the biceps tendon is here in the arm, and it runs up into the shoulder. So if we look at it like this again, so our bicep starts down in the arm and then runs up into the shoulder joint. They state that there's moderate intra-articular tendinosis. So the intra-articular part of the biceps is the inside the joint part of the biceps, not the outside part of the joint. They say that there's no labral tear. The glenohumeral chondral surfaces are well preserved. And so when they say that, they're referring to the actual ball and the socket joint. So the glenohumeral joint, it's the ball and socket joint. And the chondral surfaces, meaning the cartilage of the joint, is well preserved, meaning it's intact, it looks good, they don't see any problems. They do see, however, a tiny humeral head spur. So the medical term we use for that is an osteophyte. And we often see that when you do start to see a little bit of wear and tear in the joint, but they're saying that they do see this small spur. Small glenohumeral joint effusion. An effusion refers to fluid inside the joint. That can be caused from different reasons. It can be from trauma, inflammation, anything that can cause a fluid buildup. We'll call an effusion. They see a small joint effusion, and then they see subcoracoid bursitis. The coracoid is a bony protrusion right here on the so if there's looking at our shoulder, we turn the shoulder this way, and the coracoid process is this finger-like projection off the shoulder blade. That's the coracoid, and so when they say the subcoracoid bursa, they're referring to the space underneath it, so right here in front of the subscapularis tendon. So there's a bursa there, which is that low friction layer where the muscle can glide, and what they're saying is that bursa looks inflamed. They say mild synovitis. They're just saying the joint sounds inflamed. The synovium is the lining of a joint, and they can tell there's inflammation of that. And then finally, they report normal IGHL. What they're saying is that the IGHL, which stands for the inferior glenohumeral ligament, it's a stabilizing ligament in the shoulder. It looks fine. Next paragraph, type 1 acromion without tilting. So remember, the acromion is this projection off the shoulder blade, sort of like the roof above the rotator cuff. So the acromion's here, rotator cuff down here, and they're saying this is a type 1 acromion. So again, they're just referring to the actual shape of that roof of the acromion. They see moderate AC joint arthropathy with spurring. So the AC joint, the acromioclavicular joint, that's where the collarbone meets the shoulder blade bone. They see arthritis there. That's what they mean by arthropathy. Arthropathy really, just think of it as meaning as arthritis, where the cartilage of the joint's wearing out. And then they say spurring, which, again, spurring really just means an osteophyte, which is a sign of arthritic change. They see subchondral cysts, which are also a finding we see with arthritic change, and a joint effusion, which again we see with an irritated joint, where you're getting some fluid buildup as a result of that irritation within the joint. So moderate AC joint arthropathy with spurring, subarticular cyst, and joint effusion. That's just a really fancy way of saying this joint has arthritis. They see subacromial and subdeltoid bursal fluid collection. So remember, the subacromial space is the space between the acromion and the rotator cuff. There's the bursa there. And the subdeltoid space is the space underneath the big deltoid muscle. So the deltoid totally covers this whole part of the shoulder joint. So they're referring to that whole space as well. And so they see bursitis, and inflammation of the bursa at that level. They say the bone marrow signal intensity is otherwise normal. And the signal intensity of the muscle groups is normal. And so they're referring to signal intensity, which is essentially the appearance of the muscle on the MRI scan, the appearance of the bone on the MRI scan. And different things can cause the muscle to appear differently. You can see the muscle might appear a little bit brighter, which would be reported as a higher signal intensity, and that can happen with like a contusion, if there's bleeding in the muscle, or other problems in the muscle or the bone. So that pretty much wraps up case 2. What we see here is the overall impression. The radiologist sort of provides us with a more of a brief summary of everything that they've described up top, and so that's just covered in the impression there. So now we'll move on to the next case. All right, so we're going to start our third case, and all these shoulders are the right shoulder. That's just a coincidence. But so we can see again, it's an MRI of the shoulder, right shoulder without contrast, and all the same things we've gone over before: the clinical indication, the technique, if there's a comparison study. In this person, they make note that they have access to comparison studies of a right shoulder regular x-ray from October 2023. And this patient actually had a right shoulder MRI in July of 2022. So this is helpful to the radiologist because it's sometimes beneficial to be able to compare a more recent study to an older study. So moving along to the findings. So they say again, which they're referring to probably, they even saw this on the previous shoulder MRI scan from July 2022. So again, there is moderate supraspinatus tendinosis, wear and tear of the tendon, if you will, with full thickness tear of the distal mid fibers. So the supraspinatus is one of the rotator cuff tendons, and they're being real specific where they're describing it. So they're saying distal, which is towards the end of the tendon, and mid fiber. So just kind of towards the end of the tendon here. And they provide some dimensions of the tear. So in this case, they're saying it's a 0.6 centimeter AP diameter fluid-filled defect. And so 0.6 centimeters, about 6 millimeters. So it's pretty small. It's not a big tendon, but it's a big tear, but it's there. And when they say fluid-filled, there's some fluid within the tear itself, and that can actually make it easier to see some types of, or easier to see rotator cuff tears. They see 0.5 centimeters of tendon retraction, so they're referring to the tendon attachment to bone, and it's retracted about 0.5 centimeter, so about 5 millimeters. There's no muscle belly atrophy. Overall, the rotator cuff tendon appears similar to the prior examination. So that's helpful because this patient probably had a small tear before. It was giving them some problems. It was felt that an MRI was warranted to evaluate the shoulder, and they saw this small tear. And one of the things about rotator cuff tears is that sometimes they can get bigger over time. And so on this new MRI, what they've been able to see is that tear actually hasn't gotten bigger since the first study. So again, moving along, there's moderate infraspinatus tendinosis, articular sided fraying along the critical zone. So what they're referring to in this situation is if you look at the rotator cuff on this model, we have the rotator cuff out here, which would be away from the joint, and then there's the rotator cuff that you can see when you look inside the joint. And so the outer side here is called the bursal side, and the side along the inside of the joint is called the articular side. And so when they say that there's articular sided fraying, they're referring to tearing of the tendon that's within the joint part of the tendon. And then they mention what they call the critical zone. We don't use this term very much in orthopedic surgery, but I think radiologists use it more. And after asking my radiology friends, they're really referring to the tendon between the muscle and the actual attachment to the footplate, to the footprint, I believe. The whole tendon is critical, by the way. So the subscapularis tendon is unremarkable. So good. So the subscapularis part of the rotator cuff looks fine. No problems there. And what you might notice is, of course, there's 4 tendons of the rotator cuff. Most of the time you see problems in the supraspinatus, infraspinatus, and the subscapularis. It's not very often you see problems with the teres minor. So moving along, we see the long head biceps tendon is normal. Negative for the labral tear, or for a labral tear. The glenohumeral chondral surfaces are well preserved. So really the inside of this patient's joint looks good. So the biceps looks good all the way from the outside of the joint running into the inside part of the biceps tendon. The labrum, which is a ring of cartilage around the socket, that looks fine. And the cartilage of the actual ball and socket joint is well preserved, meaning it looks good. There's no signs of arthritis, trauma, or anything like that. There's no joint effusion and a normal inferior glenohumeral ligament. Just of note, sometimes the radiologist will point out that the IGHL here, the inferior glenohumeral ligament, appears thickened or inflamed, and this is a finding they will often point out to suggest that the patient might be developing a frozen shoulder also called an adhesive capsulitis. So maybe be on the lookout for that if you see that on your MRI report. Let's see, we'll move down a little more. So they mentioned the type 1 acromion, again, the shape of the acromion, mild AC joint arthropathy, mild arthritis at the small collarbone joint, minor spurring, so a couple small osteophytes, and small subarticular cysts. So again, arthritis of the AC joint is really common, and they're just pointing out just some findings of that. Subacromial subdeltoid bursitis with a small bursal fluid collection. Again, just like in all of our other reports, that space under the deltoid, under the acromion, that bursa, it's just a finding of just some inflammation to the shoulder. The bone marrow signal intensity is otherwise normal. Signal intensity of the muscle groups is normal. And so obviously those are all good findings, as we've mentioned before. And then finally, we've got our overall impression where they summarize everything. So that pretty much concludes our third case. Well, there you have it, guys. Hopefully, by going over these reports, we've been able to put some of this terminology into context and to help everyone start to understand what they're seeing when they read their MRI report. The MRI reports that we went over today are more typical for older patients, 40s, 50s, 60s, and above, where there's a lot of wear and tear findings and tearing and things like that. You can see some of the tearing with traumatic injuries, but probably, at least in my practice, a lot of what we see is in just overuse and wear and tear over time. So these types of reports tend to be more common in shoulders in patients who are older, 40s, 50s, 60s, and above. In our next video, we will talk about MRI reports in younger patients, high school athletes and college athletes, and patients within those age groups, and some of the findings that we see tend to be a little bit different. And so we'll try to get that video together so you guys have an opportunity to review that as well.